say Kaiser. Kaiser is only on Oahu and Maui, and then Ohana and United. And so for our health coordination services, and so for those of you over the past few years, you've probably already figured it out, with the RFP, a lot of names changed. What used to be service coordination is now health coordination. So, our health plan's basic role with them is to coordinate the care for members, providing that continuous coordination of care across the continuum, whether that's, everything from home and community-based, nursing facility, foster, wherever our members are at. So really making sure that we can help and assist the best way possible to coordinate that. It's a team approach. So our health coordinators can be either nurses, an RN, an LSW, or an LCSW. And then part of the new RFP, they also brought in a non-clinical portion of that team. So they may also communicate with a lot of it is the same roles across the plans, but may have different titles. So some of these are an AHC, the Assistant Health Coordinator, Care Coordinator, CHW is Community Health Worker, Peer Support Specialist, or Health Coaches. So again, maybe slightly different titles across plans, but the roles are probably pretty similar. So the role of our actual health coordinator, that primary health coordinator on the cases, the focus is to improve healthcare outcomes. So we do that by all the obvious requirements, right? We're doing that health functional assessment that's required for every member. Some of those changes with that latest RFP was, it's at least annually now versus it used to be quarterly, unless there's a significant change in the member's health status, which would be a child that goes into foster, right? That's a major change in that person's life. So that would prompt an HFA. From that HFA, it then goes over and develops a health action plan. So that's really kind of our working document. Other people refer to it as a care plan, right? So that's where it's got all the information that's needed. That gets reviewed with that member and updated quarterly or more often if the need arises. For those members that appropriately need one, we would do the 1147 or the child version of it if they're a med-frag child who has, who needs that requirement. A collaboration across whatever is needed, whether it's with agencies such as CWS or DDID. And then the coordinator is there to really coordinate, facilitate, and arrange access to services that they're eligible for. We identify any care gaps, significant changes, and approach those. And then also the health prevention, promotion, and disease management. So really that health coordinator is the focus of a lot of care for that member. This just kind of broke it up to some, as you all well know, right? Healthcare, Medicaid in general, there's a whole lot of acronyms, but these are some of the key ones within health coordination and the different, for lack of a word, program. Some of us refer to them as cohorts. So the SHCN, that's our special healthcare needs. So a lot of these kids in foster would probably fall within this. They may not have a whole lot of real complex needs. They're not a med fragile, but just based on the fact that they've got so much going on in their life, they've had this new setting change, living environment, caregivers, they would pretty much all fall into the special healthcare needs. So this is folks that have, either a physical condition, chronic condition, behavioral, developmental, emotional. And then we have the expanded healthcare needs, which basically meets everything that the special healthcare needs does, but the member is a bit more complex condition, maybe in and out of EDs frequently. They also have a mental health condition to go along with it. So if you kind of think of it as kind of a step up from the special healthcare needs. And then we have the LTSS, or our long-term support and services. So these are folks that they're meeting that much higher level of care, nursing facility level of care. For those that are appropriately going to have an 1147 done. Excuse me. Or we have the whole population of at risk for deteriorating. So some of these may not be so much for some of these kids if they don't quite fall into this category. I think most of them would probably fall into the SHCN or EHCN. CAS would not apply to your kids. This is that, well, it might, I know, probably really won't because you're putting them into stable homes. But the CIS, community integration, these are the folks for housing needs, right? They're homeless, about to become homeless, chronically homeless. So there's that entire program under health coordination. And then the GHP, or Going Home Plus, or Money Follows the Member, a couple different titles for it. These are folks that have been institutionalized long-term and then they're going home. Now that may come across it, especially if we've had a child, this happens a lot. Child's been stuck at Kapiolani for a really long time because there's nobody to take the child. They've now found foster, resource caregiver. We would be looking to have that person into the Going Home Plus program. It just gives a higher level of monitoring, following, assistance, getting them out of the facility into the community, and then keeping going with that child until, everything is kind of stable. So you will come across that, or the resource caregivers will. Sorry, I know that was a lot. And again, you'll have these slides to refer to, but that's kind of the basic programs within health coordination. Again, it just kind of goes through and shows it in a different view, but assisting with MD appointments, coordinating that transport, providing health education support, finding resources. So the key thing for that is just letting these resource caregivers, the purpose for health coordination, and really getting across to them, this is a partnership, right? We want to be able to work with all these kids and with all these resource caregivers. We've come across, and I say we because we've talked about it, and I think we all agree, we've come in situations where we reach out and we try to assess the child for needs, but these resource caregivers, especially if this isn't their first foster child, they're like, no, we're good, I don't need the help. But we would really like to encourage that they do, at least initially, work with a health coordinator, get that HFA, get the assessment done. And if it comes to find out that, okay, there aren't any gaps, this caregiver does have everything set, they've done everything they need to do, then it's not like we would have to continue with them. But highly recommend that they do work with us just to kind of help and assess that, especially if the child's just in their home or they're a newer resource caregiver. Again, it goes through the LTSS and HCBS. These are folks that are needing services in the home, right? Whether it's environmental adaptations, home modifications, additional services that caregiver doesn't provide. So it's there, a little bit more detail, but a lot of these kids probably aren't going to fall within that. So in that situation, we're probably much more involved and we would already be working with that resource caregiver. Some state and federal requirements that dictate what we do. So there are NCQA standards that apply. There's a lot of state timeline requirements. And so that's important for these caregivers to understand. We're not nagging them when we're calling to set up these appointments for assessments. There's requirements, right? They have to be done within a time frame. That health action plan gets reviewed every 90 days to keep it up to date. We do have to comply with the RFP from DHS. A lot of this data we're collecting goes into quarterly regulatory reports back to MedQuest, so keep us, again, compliant with that. If this child is disabled, then there's some DSNP requirements that they also have, Medicare along with their Medicaid. All of our records are subject to audit, so we have to make sure that things are done completely. And then, well, this is kind of gone now. This was back during COVID, but, we did do telehealth and a lot of stuff instead of the face-to-face visits, but we are now all fully back to face-to-face. So my apology, I probably should have took that part out. So here's the contact numbers. If any needs, any concerns, need to get hold of somebody and ask for health coordination, see if there is a health coordinator assigned, any needs around health coordination, this would be your contact for each plan. And that was pretty much the last slide. Like I said, it was just kind of high-level overview of what health coordination is and what we do. And I kind of did mention about how we really want to encourage to have, as you folks are reaching out and working with these resource caregivers, to make sure that, when they're getting a call from a health coordinator, this is why they should go ahead and work with us, what we can do and what we can help with. Or if they haven't had a call yet, or maybe they had a call in the past and now things have changed, that resource caregiver can definitely reach out to the member's health plan and ask for a health coordinator. Any of the other plans on the line have anything to add to that, or something I missed that might not have been on here?
Hi, this is Tonya. I had a question. I'm with Child Welfare.
Mhm.
So in terms of making a referral for care coordination, um, I know you mentioned resource caregivers, which our kids are in foster care. Sometimes cases we get where kids are in the home.
Mhm.
So care coordination is open to birth families or any
Oh, yeah.
caregiver for a child with. Oh,
Definitely. So wherever that member is at, and I apologize. I mean, I know it's focusing more because we had talked a lot about the resource
yeah.
caregivers and the kids in foster. But yes, if the child has not, maybe CWS is involved, but they have not left their parental home yet, of course. I mean, probably even more so, right? If the parents have needs, there's stuff that they're having trouble coordinating, and we want to try and do the best we can to try and keep that child in their home. They too as well get a health coordinator, and we can work along with CWS, the parents, the child, making sure everybody's got what they need.
When we call that number that you listed, what information would they need from us? Is there
Well, I mean, I can speak for Ohana. I mean, that number is our customer service line. And if they're basically just saying, hey, we need a health coordinator or checking to see if there is a health coordinator, we would really just need the member's name, which is the child, and their Medicaid number, or if they have their health plan number.
okay.
And then it would go from there. They would check in the system, verify that, yep, this is an Ohana member or whichever plan they're calling. And then they will get them to that right person or get somebody to call them right back to set up that assessment.
Okay.
Same with
Vicky or
HMSA.
Donna Lay.
Hi, Mona. This is Donna. Sorry. Same with HMSA. Call the number and then ask for either if they already have a health coordinator or if you're requesting one, then we will, just the member's name and their membership number and birth date. That's it. And a contact number.
One thing I've noticed when sometimes the children that we come in contact with have had existing either health or mental behavioral health issues. And what I notice is when we reach out for care coordination, they already have a care coordinator. It would be like, there's no way to tell that just from, I don't know, probably not.
No, I know there had been discussions before, and I think United, they may or may not still do that. They used to put the health coordinator's name on the card, but as you can imagine, keeping up with that, because health coordinators do change for various reasons, they'd always have to then be issued a new card. So we've chosen not to put that on the card, but they can always find out who that is by calling the number. And it's hard because, the families get, just kind of thrown so much information. When we have somebody assigned, they go out and they do that assessment. There is a letter that gets left behind that says, okay, I'm your health coordinator. Here's my number. Here's my partner care coordinator. So they have all that information, but it gets misplaced. They forget they have it. So there's a lot of times they're like, oh, I don't know if I have a health coordinator. And in reality, we just talked to them a month ago or whatever. So it's always, if they don't know or they can't give you the name or number or anybody, just reach out to the health plan and we can get you that correct information and get you to the health coordinator assigned.
Okay.
And they're pretty good. Like I get regular emails from different people within CWS and APS. Well, probably more APS than CWS, but they'll reach out and say, hey, I've got a member. Do they have a health coordinator? And then we're able to connect them right up.
Mm-hmm. I was wondering if we could go back a slide or maybe to
Which one?
It was like, maybe this is the one. So are these the reasons or that you would access care coordination or?
Yeah, I mean, so these are kind of the different, for lack of a word, levels of health coordination.
Okay.
But if you're trying to think of a reason for health coordination, it's just kind of what it says. It's that coordination. If that parent or that resource caregiver needs help coordinating, navigating anything within that child's care and the health plan,
Okay.
then they can reach out and check. Now, it may be that once we do that assessment or we see what it is, they may not need a health coordinator. They just needed a couple things answered. Example, sometimes they'll call and reach out to us because they need to find a new pediatrician. That may be their only need, right? So we'll assess to make sure nothing's being missed, to make sure that all their needs are being met. And if truly their only need is to find a new provider, we can assist with that, make sure they got that first appointment, and then they may never need to continue with that health coordinator if all their other needs have been met. But sometimes they think their only need is to find a provider, but then we do that assessment and we're like, well, what about this? And what about this? So often we can find other things going on. So, we'll keep them a bit longer to make sure everything's being done.
What kind of assessments do you do?
Well, if they're accepting and working with a health coordinator,
Uh-huh.
it's the health functional assessment.
Okay.
It's what I've lost track because we just updated it with MedQuest. It's, I don't know, probably about 50 pages. It's a very detailed, in-depth, looks at everything.
Oh, and the caregiver completes it, the patient
Well,
combination.
typically it's the POA. If it's a child, obviously, right, they wouldn't be able to answer a lot of it. We would incorporate the child if they're able and of age to understand and share. But so
Uh-huh.
it's a combination between the child, the caregiver, the POA, sometimes the doc provider. So it just depends who all needs to have input in it.
Okay.
And obviously, if CWS is in some of that stuff, we may need to reach out to the CWS worker to see, because sometimes you can imagine where the parents may not necessarily be completely truthful on some of it. So if we know CWS is involved, there would be collaboration with you folks just to kind of get some more information.
So some of the kids that come into care or we come into contact with, have experienced trauma and have mental health issues, or they might not have been diagnosed based on, like, let's say their age.
Mhm.
Like in terms of like calling out, like, I guess would that be like this SHCN or the special healthcare needs, or?
Well, they would probably all kind of start out for special healthcare needs. And then if we find
Okay.
out that, okay, maybe they do need a full assessment, maybe we're making a referral for, CAMD or whatever that need may be, and getting them to the right resources, or maybe they're working with that POA caregiver to say, hey, maybe the child does need to be evaluated by psychiatrists, psychologists, and see what's going on. So we're going to refer and utilize all of the different services and agencies that are out there to get what that child needs. Because obviously, right, we're not the one diagnosing or identifying that. Based on the assessment, we're looking for gaps, we're looking for needs, getting them into those right resources, getting the right visits done, and then going from there.
Okay. Okay, that makes sense. So
If
in
you kind of
general,
think of it, health
yeah.
coordination is it's like a hub, right? If you kind of picture
Uh-huh.
health coordination as the center of that hub, us and
Uh-huh.
the child. And then you've got every other resource, agency, everything else that's out there available within the health plan, or even not the health plan. If something's not covered as a benefit, then we look at other community resources as well. So if you just kind of look at that health coordinator and that child in the middle, and then we're going to look at every possible thing within that wheel to get to that child to make sure that their needs are being met.
Okay.
And the family, if we're finding that the family needs support or education or treatment. It's not like we're gonna just treat the child. Well, it gets a little trickier if the parent doesn't have the same health plan, then you got to collaborate. But yeah, we're gonna look at that whole setting, that whole environment.
And CIS, is that like part of the health plans, or?
So yes and no. So CIS itself is part of the state, but all of the health plans have people within the health plan that work with CIS. So we all have housing coordinators to help folks find housing if they're homeless or about to be homeless. They work
Oh,
within that CIS system. There's outside agencies in the community that are doing the assessment and a lot of work with this population.
ah, okay. So if we have a client that we're working with that's homeless on MedQuest, um, that
I would
also
say
could.
refer those. Yep, I would say if you've got those and they don't already have, somebody within the health coordination department, I would reach out to the plan. And then we will
Okay.
make sure that our housing coordinator does have them within the CIS system, making sure that they've got, all of the assessments that they need to try and get housing. Yep. I mean, chances are they have, but we don't want to miss anybody and let them fall through the crack. So it would never be wrong to just have, reach out to the plan to see if we already know about them and if they're already working with them and in the system.
And then if we had former foster youth, like, so once the youth turns 18, there are some services we can offer to help support them, but not always guarantee like a living arrangement. So we could refer to the health plan to assist with
Yeah, definitely that's a tricky transition, right? Going from
yes.
child to adult, and especially aging out of foster. So yeah,
Yes.
and again, that's a huge, so even if this child had done fine up until now and they weren't having any issues, to me, my interpretation, that's definitely a member with special health needs, because that's a drastic change in their life that could then lead to any one of these other issues. So
could we refer like our foster youth like before they age out of care, like at 17 and a half? Like if they didn't have any kind of, which I find unusual, but if they didn't have like any kind of physical or mental health or behavioral issue, we could refer them for CIS.
I can speak for Ohana, and I would say yes, make that referral for health coordination, and then we're going to look to see what all their needs may be. CAS gets a little trickier, right? Because if they weren't homeless before, then they don't qualify necessarily.
Yes.
But if they're about to become homeless, if they're having to leave that foster home and you folks don't have a place for them to go, then they could be potentially about to be homeless, which would qualify them. So there's a whole lot of different little pieces to look at. But I would, from Ohana's side, and probably the other plans, I would say refer them as they're about to age out, just so that we can do the assessment and see what needs there may be. And then we would work in collaboration with you folks and whatever other agency is out there.
Okay. Okay. Thank you.
That's a tough one. I'm just curious, on an average, how many at any given time do you guys have in the state that are about to age out of foster like that? Do you know?
We do have like this all in care list, and I'm not even sure right now. And we try really hard like to find them a place. But and then usually the ones with more behavioral mental health issues, they sitting in shelters, because our shelters have certain rules about once the child like turns 18, you can't mix like an adult with like children. So that's usually when they need to leave.
Find another place.
So yeah. And I don't have that. That is a good thing to look at. Yeah, that number.
Yeah, it might be a good place to start. Just see at any given time, what are we looking at for them? And how many of them really don't have any place to go? And
yes. And target that group, yeah. Okay.
The eligible age starts at 18 and older, so it is a potential benefit.
sorry, I think you cut out the very first part, Vicki. What's the benefit for?
I said the member has to be age 18 or older, so it is a potential. CIS is a potential benefit.
Oh, for CIS, yeah. Because prior to that, they're looking at the family and the parents, right? So, but for the child themselves, once they're 18. Yep. Because the last thing we want, right, is these kids to have done well within foster system and then they end up on the streets because they have no place to go, right? Nobody wants that to happen. So the earlier we can all intervene, I'm sure the better results.
Yes.
This has been wonderful, Mona.
Yeah. Yeah, thank you.
Are there any specific questions from, I'm curious to hear from any of the workers that are actually working with some of the resource caregivers. is health coordination kind of routinely suggested or mentioned to these resource caregivers, or and if it's not, that's okay, because probably a lot really weren't aware of what we are and what we do and, why they should be referring to us. So just kind of curious what the workers themselves out in the field, what the families have been seeing or hearing.
Well, I'll go ahead and ask maybe a warm-up question. What about, there's several folks that are involved at CWS in the child's case, and a lot of times it's their SSA 4, social services assistant 4. It's not the social worker necessarily, but the SSA 4s are really kind of in the know in the day-to-day kind of things, and communicating with resource caregivers, and helping to schedule things. Is there any limitation to talking with those members of the CWS team with the health plans from the health plan?
I, I wouldn't think so.
Hey,
I know we kind of cleared up that
hey,
whole confusion about HIPAA and who they can or can't talk to and all that. So yeah, I don't think there would be.
hey, Mona, it's Janai.
I
Can I add to this question or to this response? So I think the SSA could and probably be okay with attending the assessment and with the child. The only issue I think that we would run into is when it's time to complete the service plan, it needs to be the person who has responsibility over the child. So then it would be the assigned social worker or human service professional to sign that.
yeah.
That's a great clarification.
Yeah, because the HFA, the assessment, that's, often a kind of a team approach, get information from multiple sources. But yeah, to Janai's point, so good call out. Once it comes down to putting it all together and on that HAP, it is more just that responsible person.
As you asked about the SSA 4s, I thought about we process a number of adoptions and guardianships. When we're not able to reunify children, then we move on to another goal of like adoption or guardianship. And then what happens is the families that adopt or take guardianship of a child qualify for like adoption assistance and permanency assistance, which is monies equal to like the foster board and any difficulty of care rates we might be providing them. And then what happens is these are like turn into like payment cases, and our service cases are closed. And many of and the payment cases are primarily assigned to SSA 4s. And what happens is as the child ages, many times, let's say an infant is adopted or a younger child, and then as they hit school age and teenagers, then some possible like mental health issues might come up or behavioral challenges that the parents are struggling with. And many times we reach out to DOH, Child Adolescent Mental Health Division. But as you talk, I guess a referral for care coordination might be helpful. Do you think, or do you think that would be an appropriate referral? Like if an adoptive parent called and was struggling with
I,
behavioral challenges?
yeah, I mean, I don't think there's ever a wrong time or reason to send over. Worst
Okay.
case scenario, we assess and they just needed a couple of resources and they're all good to go. So that would be the end of it. Or it's somebody that, yeah, they're going to need some hand holding. They need some coordination throughout this process. Make sure they've got those first. Yeah. So it all depends on that assessment
Uh-huh.
and how much help that they continue to need. And we want to make sure, because sometimes if they're adopting or considering adopting, they want to make sure everything is kind of set, right? I mean, so
Well,
we
what
want to be able
happens
to help,
is
we want to be able to
sometimes,
help with that.
yeah, so what happens sometimes, yes, if there's services we can put in place before, we try to do that. What happens sometimes is someone might adopt like an infant or a very young child that doesn't, and then as they grow, um, you know, enter school, might have some
The needs
learning,
change, right?
yeah, needs change, and as they grow, might have developed maybe some possible like mental health or behavioral challenges. That's just what we have seen actually in practice.
Yeah, and we've had people come in and out of special healthcare needs, right? It's not, LTSS is a little different because most of those folks, they've got, complex medical needs, they've got services to make sure they can remain in their home. Those folks stay on long term because those conditions don't really go away. But we'll have people come in for special health care, they get assessed, we help them, they're like, I'm good, they're really stable, they don't have any needs. So then we may actually not follow them anymore. And then to your point, year or few down the line, something has changed. It's like, oh
Uh-huh.
shoot, I really need that help again. Well, then refer back in and we can work with them again. So they do kind of come, we have had them go in and out of that special health care needs based on their needs at the time.
Okay. Okay.
And anyone can refer for health coordination. So even those adoptive parents could call and request for health coordination themselves too.
Yep,
Okay.
for sure. So that's why it's kind of nice if, we're kind of always in all of the workers' back pocket. So,
Yes.
depending on what's coming up and what they're saying, it's like, hey, I think it'd be helpful to talk to your health plan's health coordinator. Because a lot of them don't think of that unless they've dealt with us before or they're aware of what services are out there. They think of the health plan as, well, you're paying for my doctor's visits, right? They don't realize
Yeah.
this other level under Medicaid.
Yeah.
And so it should always be kind of put out there as if you're having any kind of issues with your health care, any needs within that or coordination within the system and the health plan itself, refer them over.
Oh, okay.
Because again, the worst case scenario, they don't really need a health coordinator, but we'll do that assessment, we'll get them what they do need, and then they can move on. But then they can always reach back out again if, oh, now I do need one.
I was wondering, how does health coordination work with, like, let's say there's like a child that's receiving like Department of Health Child Adolescent Mental Health Division services or DDD services for developmental disabilities.
We collaborate and work with them. So there's some stuff, depending on the need, that we are primary and then that other agency kind of supports, or they may be primary and we do some wraparound. So like there's certain services within DDID that they provide, but if they
Uh-huh.
need more than what that's providing, then sometimes we would put in additional services. So it really varies based on the needs of the individual child. But yeah, we work collaboratively with all those agencies.
Oh, okay.
So it's not like you get this, but you don't get that. They could literally have, and we've had it happen, you'll have somebody who's got us with a health coordinator in, they've got a DDID. Sometimes depending on the age, they've got, the early intervention specialist. So some of these
Yeah.
kids will have multiple agencies working with them.
Mm,
And then you
okay.
throw in CWS to the mix, right? So we're kind
Yes.
of all involved. And we all have the same ultimate goal for that child, but we just have to make sure that we're communicating and, working with each other so that, one, we don't want to be doing any kind of duplication, right?
Uh-huh.
And we also don't want to miss things because sometimes, well, the parents already told 3 other people, now they don't want to turn around and tell us. So again, that, setting up an IDT, kind of having a conference, and we've done that. I remember one child who was pretty young. I think she was just about to age out from
Uh-huh.
early intervention. And so we'd had a huge IDT meeting in their home with early intervention, DDID, the agency providers, our health coordinator. Like there probably was 10 or 12 people in that home with this parent to make sure that this transition took place and that she had everything she needed.
Uh-huh.
And it was a really sick child. At one point, we were even talking hospice. Like there was just a lot going on in this household. And so there was so many people helping the parent.
Oh, okay.
And
You
I'm sure
mentioned
every other health plan has just as many examples like that. That's not a unique situation for our Medicaid population, unfortunately.
okay. Thank you. This is very helpful.
So we can work on just kind of a one pager that, based on some of the questions, we'll make sure we could probably outline a little bit better. Like these are the kind of things that you would top of your head think of reasons to refer.
Uh-huh.
And then we can include these phone numbers and all of that. It's just we realize creating any kind of a document like that, if it's going to be kind of a leave behind for the parent or the child, it has to go through approval with MedQuest and all of that. So we will work on that and get it approved. And then that way you folks can have it for your own use, but then you can also leave it behind for anybody that might have questions about health coordination.
That sounds good. Yeah, that sounds good.
Yeah, I'm wondering if there's anyone else that has questions. Don't be shy. Mona is awesome. She'll have an answer, and if she doesn't, somebody else will.
Oh, yeah, no, that's why we've got all the plans here, because guarantee there's going to be a lot of stuff that
Yeah, it's always, that's why we meet regularly, Mona, right? Because there's always some kind of question, some kind of issue that comes up. It's like, oh yeah, well that's covered by Quest, right?
Yeah. And it's usually because nobody questioned it, right? We assume people know all this stuff, but they don't. Just like we don't know. We definitely don't know all the stuff that CWS does. There's
Right.
so many intricate levels and things that you guys do. So, and I think it's been a while since we've had anybody from CWS like kind of speak to us on a higher level as far as services and what you do and like that aging out process and all of that. So we
Uh-huh.
might ask to kind of share and do the same thing and have you come speak to us.
Yeah. Yes. Please reach out to me and then we can set something out. I know like a common thing that comes up is mandated reporter training. But yeah, in terms of other services, we can try to arrange presentations so your health plan staff can have that information.
Yep, I think that would be helpful, especially if we're going to start looking at, some of these aging out youth, just so our
Yeah.
health coordinators and our staff know exactly what, should be done or what's already being done so that we can complement and make sure that that stuff happens.
Yeah, and I know as Sharon mentioned, we started really collaborating on this pilot based on this affinity group that was created through the Administration for Children and Families, which provides oversight over our agency federally. And I was on a meeting earlier today regarding the different HUD vouchers that's related to um, families that touch child welfare agencies that can access different voucher programs like Section 8. And Ohio and another state, Illinois, did some presentations. And one state looked at because many of the families we serve are are poor and struggling, and they're accessing TANF and SNAP. And then when children are removed, those benefits are lost. And so one state was looking at, as they're reunifying, providing SNAP and TANF benefits 90 days, and that's always hard, like to approximate when a child's going to be reunified, but to try and access services prior to the child being reunified, so they can already have access to food and funds to help support the child. Kind of similar to the conversation, what we find like a child that exits foster care isn't eligible till they're 18. And then by waiting till they're 18, it's sort of because there's always a process, right? For, usually there's like a 30 to 60 day application process. So really what that means is that someone might be without for, that application period. So I know I'm just rambling,
Yeah.
but
Well, yeah, it's a catch-22, right? It's like, okay, well, then we'll provide all that early. Well, but then at 17 and a half, they can't because they're not eligible yet, right? So they're just kind of caught in the middle.
yeah. I think the federal government is kind of looking at different transition periods, because yeah, it's not real realistic, right? To wait. I think many of our programs are realizing that, from adult services to child services. Like sometimes the child has to be 18 before we can make referrals. And then in general, like for child welfare, we can only like maybe make decisions regarding children. We can facilitate once they're 18, but it was be ultimately up to them. So it's just, I think that's the point of meeting and information sharing, is so we can better collaborate and maybe advocate for some changes in some of our eligibility criterias at times.
Hey, Tonya. This is me, Nico. I'm an assistant here. I have a
Hi.
question.
Sure.
I help with the Imuakako kids. Those are kids in the Imuakako program that's like from 18 through 24 or 21. And I was wondering if for those who are already of age, if they can be referred and doing your folks assessment to see which category they would fall in, like the CHCN, EHCN. Is that like a possibility?
I mean, we can, looking at, I mean, what kind of a need do you think they have? Because if this is, I mean, I hate to have you refer everybody over only for us to assess and say, oh, well, this child really doesn't have any needs. There's nothing we can do. If you're very specific on referring, it's like, okay, well, this child is aging out. They need help with housing or whatever, or they have some type of chronic physical condition or behavioral condition. So if there's some of that information to refer them in versus referring them just for an assessment with
Okay.
absolutely no needs. I'm sorry, I know that kind of contradicts where I say, well, it's always better to send them
No.
over. I mean, I just
No,
want to,
makes
I think it's
sense.
just because that age gap is kind of an odd one, right? If they're 18 to 21 and they're actually healthy, their only need is probably housing. Yeah, I would refer them because then based on their health plan, we have a housing coordinator who can help work with them for housing options.
Well, we
So I
have
would
this
definitely
kind of,
refer them.
oh, okay, I'm sorry. Thank you, Mona. But to carry on to that, we have this 19-year-old that was going to go into the program, but then recently he had, I guess, confrontations with his grandma that was the caretaker. And then now the girlfriend's pregnant, and he's like 19, 20 years old. So he kind of stopped the process of going into Kako. So would he be like a good candidate for us to refer him over?
I mean, you definitely could. And, we can assess and see what needs are, even if there's nothing within the health plan benefit that he needs. Part of that health coordination is then looking for other community resources and things, making sure, okay, are you tapped into this other program? Do you know
Oh,
about
okay.
this kind of thing? I'm curious. So Imua Kako, I've not heard of that. What program is that?
That's one of our programs. Go ahead, Tonya.
No, you did very good. So we have the federal government through Administration for Children and Families, the one that oversights a number of years ago to support children exiting care. s- Um, they had this extended foster care program, and we call it Imuakako. The name came from our former foster youth and our different. We have different groups of former foster youth, are we call them high hopes boards, that kind of advocate in the legislature, and we use them, and they named our extended foster care. So Imuakako is like our extended foster care program. So we don't have placement responsibility of these young adults, but we can provide like our foster board monies. Like I said, that's families that adopt and take guardianship, that those monies can be extended. Same with kids that exit care. They have to agree to be part of like our IL provider. And there is even like a sort of a court petition process, but it's considered nationally, it's known as Extended Foster Care to 21 program. And that's what it is. That's what Imokako is. Yeah.
So any that have exited out at age 18, if they just decide and they're good on their own, they move out, they find a place, they're kind of done. But maybe
Yes.
there's this group that don't have a place to go, then they kind of stay in this extended program and they're getting some services.
Yeah, and primarily it's the money that follows them. And the money it's less the difficulty of care costs I talked about. So it's the board, which is like I don't know, what is it? 776. So that's not a whole lot, yeah, to survive. So that's all that they have. Unless they have jobs, then that would be supplemented. And then if they have a family they can stay with, or if they have a place to stay, that helps. But then if they don't, you can see how that's not really a lot of money to survive on as an 18 and a 19-year-old.
So where are these 18 to 20-year-old that are in this program? Do you guys have housing or someplace for them now, or are they staying in the same home they'd been in previously?
That's why we try to do adoptions or guardianships, or find families that will like commit to them and agree to like house them, but that's not always the case. And we do have, but it's very, very limited. We have, I think on Oahu, there's like two, they call it, Halekipa has ILP beds. There's like two, and there's a lot more kids that exit care than two. So yeah, that's sort of the
So
yeah,
you
it
don't
is
have-
limited.
So you don't have an actual home or place where these kids
Can go
anymore
to,
can stay.
yeah, not automatically. No.
Got it. Yeah, that definitely sounds like a
Tonya, it's
fairly
Janai.
significant gap.
Yeah.
Sorry,
Yeah.
Tonya, it's Janai again.
Uh-huh.
I used to work for Jeff Woodland a long time ago, right when Imo Kako started.
Uh-huh.
At the time, there was the ILP. Are you guys still doing that? Like they were housed in this one building, I remember, off of Keomoku. Do you guys still do that with the Imo Kako kids, or is it, are they just placed someplace else after they turn 18 when they enter into
So
Imo
I
Kako?
know Halekipa has an ILP program, and it's 2 beds for 18 and older.
Oh, it's only 2 beds.
Yeah, it's only 2 beds. And then and then we
There was
try
an
to
apartment building.
Yeah, so there might
Wow.
be other agencies like, and they're probably connected with the CIS is my guess. Like I believe
Oh,
Liliuokalani Trust, someone has to be Native Hawaiian, but they have this, is it Lydia House? And that's in Honolulu. Only they just opened, I think they have a drop-in center for homeless youth and young adults, and I think upstairs are some apartments. I'm not sure of their, but so different private agencies might have. We have used Rise. Rise is basically a homeless shelter for young adults. They used to house youth too during the pandemic, but I think they had to stop doing that last year. So yeah, it's most of kids that exit care that don't have an identified family or someone that will house them would most likely be in need of CIS
Housing support for
services.
sure.
Yes. Yeah.
were you guys doing, and it's been like 10 years since I left CWS, but do you guys do rent subsidies with the Imo Kako kids, or has that gone away? And I
So
may be
we do.
not
So we
remembering
do.
correctly. Okay.
We have a through Halikipa is our independent living agency that provides supportive services and case management for youth and young adults. So kids in Imuakako should be part of our ILP program agencies to help them. And through that, Halikipa has access to these housing vouchers like Section 8. What we just got word of like a couple years ago was youth can't access, since it's supplemented by federal funds, we're trying to advocate for that to be waived, but they can't get the $776 plus the housing voucher, which they used to. So it's one or the other.
Oh,
Do they
And-
realize the cost of housing in Hawaii?
Yeah, yeah, that's has been our advocacy. I think we've been trying to work with like the Senator Schatz and different about trying to have some kind of waiver. The feedback from the Administration for Children and Families is that 776 is our rate for children 12 and above. So what they're telling us as an agency is perhaps you as an agency should have a higher rate for 18-year-olds. Yeah. Because for a under 18-year-old, the board rate is supposed to supplement a resource caregiver's already existing household, right? And they're so they already can afford their house, is the theory, right? They already can afford their house and they're living, and then now they're housing this youth and then this extra. But for a child on their own that's 18 living out there, they only have that. They don't already have established a home necessarily, right? Hopefully that makes sense, but
Yeah, it does. And like I said, they're not going to find any place to rent for that, or they end up finding,
Yes.
some type of a boarding setting with shared
No.
rooms, and that may not be
Yes.
the best environment for them. And yeah, I just see a whole lot of issues with that.
Yeah, there are a lot of issues and struggles that are faced by this population.
Yeah, I'd be interested just to kind of see what numbers are we looking at, how many kids fall into this group. We can look to see by health plan. Yeah, that would be interesting data to collect.
I could look that up. Try to.
For Imuakako?
Or
Well, just the
I mean,
numbers of kids that exiting care.
because like you said, not all of them exiting choose to go into the Imuakako, right? Some just kind of
Yeah.
go out on their own.
Yeah.
Well, how many do you generally have in Imuakako at one time?
Like between 12 to 20. Averaging
that on-
between that much.
Is that on Maui? Is that on
Only
Maui?
Maui, yeah. That's
Yeah.
sorry, that's only for us on Maui.
But,
then there
but
would
that
be-
program is on every island, right?
Yes, correct. And Oahu would have probably the biggest population. So, but yeah, I could go look and get some numbers for future conversation.
Yeah, I think that would be interesting to see.
Well, thank you so much. It's like a minute before the end of our meeting, and I do have another meeting I have to get to. This was very informative. Thank you. Thank you very much. And thank you everyone for your participation.
If there's
Thanks.
any,
Any
Thank you,
questions,
bye.
please reach out. You've got all of our contact numbers, so.
absolutely. And
Yeah,
I'll send
and you'll send out
Yep.
the PowerPoint
I'll
and
send
I'll
this.
forward.
Thank you. Yeah, I'll send it to you and then you can send out to everybody. Thanks, Tanya.
perfect.
Have a good day, everyone. Thank you. Bye.
We'll see you next
Okay.
month.
Thanks, bye.
Thanks, bye.